Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive into something we see constantly, yet it's always sparking debate: managing vitamin D deficiency in our hospitalized patients.
It really is essential for us in hospital medicine. I mean, this deficiency is just incredibly common, particularly in the sickest patients, those in the hospital or the ICU. And just to be clear, when we talk about vitamin D deficiency, we're talking about low serum 25-hydroxyvitamin D levels. That's the marker, the 25-OHD. Clinically, deficiency is generally defined as below 20 nanograms per milliliter. In severe deficiency, that's usually reserved for levels under 12 nanograms per milliliter.
Right, those numbers really underscore how widespread this is, and the stakes feel high given how complex and acutely ill our patients often are. So our goal today, our mission, if you will, is to really synthesize the current evidence. We need to look closely at the randomized controlled trials, the RCTs, and analyze these major guideline shifts we've seen recently. I'm thinking especially of that big Endocrine Society update from 2024. We've got to figure out, who should we actually be screening? Which patients are likely to truly benefit from supplementation? And what outcomes can we realistically change?
Exactly. We need to move past just reacting to a low number. The focus has to be on an evidence-based, targeted approach. Understanding the current standard means really grappling with that strong observational data that links low levels to bad outcomes, but also acknowledging the often, conflicting results from the intervention trials.
Okay, let's unpack all of that. Starting with the basics, seems right. Physiology. Understanding the how is so critical to understanding why deficiency has such broad effects, particularly in acute illness. Can you walk us through vitamin D's central role? Maybe focus on what happens when someone is acutely ill.
Certainly. So the primary role, the one we understand best, is all about calcium and bone metabolism. It starts with vitamin D itself, either made in the skin via sunlight or from diet, D2 or D3, it gets into the circulation. Then the first key step happens in the liver. It undergoes 25-hydroxylation to become 25-hydroxyvitamin D or 25-OHD. That's the storage form. And importantly, that's the molecule we actually measure in the blood to check someone's status.
Right. And it's that next step, the final activation, that seems so crucial for balance, especially when organs like the kidneys are involved, like in critical illness.
Absolutely crucial. That 25-OHD travels to the kidney. And there, an enzyme called 1-alpha hydroxylase converts it into the active form. 1,25-dihydroxyvitamin D, that's 1,25-OH2D, also known as calcitriol. And this final conversion step is tightly regulated, mostly by parathyroid hormone, or PTH, and also by serum phosphate levels.
And that active form, the 125-OH2D, that's the hormone that's actually calling the shots on calcium handling.
Precisely. This active hormone binds to the vitamin D receptor, the VDR. These receptors are found in many places, but critically in the cells lining the small intestine. Binding there dramatically boosts intestinal calcium absorption. I mean, think about the numbers. If you're severely deficient, you might only absorb 10 to 15% of the calcium you eat. But if your levels are sufficient, that absorption jumps way up to 30 or even 40%. That's the fundamental difference for bone health.
Wow, that's a huge difference. And that dramatic drop in absorption capability must directly lead to that cascade we associate with deficiency, starting with low calcium, right?
It does. When calcium absorption tanks because of deficiency, you get this tendency towards low serum calcium, hypocalcemia, and the body responds very strongly. It triggers secondary hyperparathyroidism. PTH level goes up. And PTH tries its best to keep serum calcium normal by stimulating bone resorption, basically pulling calcium out of the skeleton, also by pushing the kidney to make more of that active 125-OH2D.
But in chronic, really severe deficiency, that compensation just can't keep up. And that's when you see the persistent bone demineralization, the osteomalacia, sometimes even that severe muscle weakness, especially proximal. That's the classic skeletal picture.
That's the direct skeletal consequence, yeah. It leads to bone pain, higher fracture risk, general muscle weakness. But for us as hospitalists, the other critical piece is this observed link with broader adverse systemic outcomes. Study after study, observational ones, consistently show that vitamin D deficiency is a strong, independent predictor of poor outcomes in the hospital, even when you adjust for how sick the patient is otherwise.
And that's the real tension here, isn't it? The strong association versus the sometimes lacking proof of causality from intervention trials. So given that, what specific adverse outcomes are we actually seeing linked to low vitamin D levels in our inpatients?
The signal is pretty consistent across several areas. We definitely see a statistically significant association with increased overall mortality. Sometimes the risk is reported as 2, even 3 times higher compared to patients with sufficient levels. Beyond just mortality, there are higher rates of hospital-acquired infections, things like CIUTI or CLABSI perhaps. There's also delayed functional recovery. Patients just aren't getting back on their feet as quickly and, importantly, significantly longer hospital stays. I remember one study, a retrospective look at pneumonia patients in the hospital. Severe deficiency wasn't just linked to worse clinical scores, but on average, patients stayed over a day longer. That's a huge deal for hospital flow.
And this has to tie back to those effects beyond bone, the extraskeletal effects. When we talk about infections and muscle function, we're really talking about vitamin D acting more like a hormone with wide-ranging influence far beyond just calcium.
Precisely. The vitamin D receptor, VDR, isn't just in the gut and bone. It's expressed almost ubiquitously. You find receptors throughout the immune system on macrophages, T cells, dendritic cells. And in these immune cells, vitamin D seems to play a modulatory role. It influences both innate and adaptive immunity, possibly promoting tolerance and maybe dampening down excessive inflammatory cytokine release.
So in a critically ill patient where inflammation is often driving the pathology, being low in vitamin D could potentially mean the immune system has less regulatory control, less ability to temper itself.
That's the current thinking, yes. And this connection might explain the link between low vitamin D and impaired muscle function, that myopathy we mentioned. That directly contributes to a higher risk of falls, slower rehab, just generally impaired mobility. And that doesn't stop there. There's growing evidence linking deficiency to neuropsychiatric issues too. Some meta-analyses have shown a significantly higher incidence of delirium and cognitive decline in deficient inpatients, especially older adults. It seems like the systemic stress of being acutely ill might both lower vitamin D levels and make the negative effects of an existing deficiency even worse.
That really does sound like a perfect storm in the hospital setting. Patients often arrive already depleted, they're inflamed, they're often immobilized. So let's dig into the why. Why is deficiency so incredibly common, specifically in hospitalized patients? What are the root causes?
It's almost always multifactorial. There's several things interacting. First, you have the basic nutritional and environmental factors. Things like inadequate intake from poor appetite or outright malnutrition. And critically, limited sun exposure, which is how we naturally make most of our vitamin D. Patients who are housebound, living in institutions, or even just admitted during the winter months often start out low.
And then you layer on the chronic diseases. You mentioned comorbidities earlier. It goes beyond just obvious kidney or liver failure, right?
Yeah.
How do conditions like diabetes, hypertension, heart failure play into this?
Yeah, there seem to be a couple of mechanisms at play there. Inflammation is one, and metabolic impairment is another. With chronic kidney disease, it's straightforward. You lose the kidney's ability to do that final activation step to make 1,25-OH2D. Liver disease messes with the first step, the 25-hydroxylation. But conditions like diabetes and heart failure are often characterized by this chronic low-grade inflammation. We see elevated C-reactive protein, CRP, and other inflammatory markers, and these often correlate inversely with vitamin D levels. The hypothesis is that inflammation might somehow sequester vitamin D or maybe speed up its breakdown.
So the low level isn't just a marker of poor diet. It might actually be a physiological reflection of the body's overall inflammatory state.
That seems to be part of the picture, yes. For heart failure and hypertension specifically, there's also evidence that vitamin D receptors are involved in regulating the renin-angiotensin system. Deficiency has been linked to higher plasma renin activity. Now, it's not proven causal, but the connection suggests deficiency might actually contribute to the pathology of these diseases, making patients sicker and perhaps increasing their need for vitamin D. And then you have conditions like nephrotic syndrome, where patients are literally losing the vitamin D binding protein in their urine, which just depletes their circulating 25-OHD.
We also absolutely have to talk about polypharmacy. That's a huge factor in our patient population. What are the key medication culprits?
This is a really critical checkpoint for hospitalists. Certain drugs are notorious for inducing the CYP3A4 enzyme system in the liver. Classic examples are anticonvulsants like phenytoin and carbamazepine, and also the antibiotic rifampin. These drugs significantly speed up the clearance and breakdown of vitamin D. So patients on these long-term often need much higher doses, maybe double or triple the usual maintenance dose, just to keep their levels adequate. If you don't account for this, you risk drug-induced osteomalacia.
And chronic GI issues or surgeries that affect absorption are another major challenge.
Absolutely. Malabsorption syndromes like celiac disease or Crohn's disease severely impair the uptake of fat-soluble vitamins, and D is one of them. And post-bariatric surgery states, particularly procedures like the Roux-en-Y gastric bypass, which bypasses a lot of the absorptive area in the gut, are a huge risk factor for chronic, often profound deficiency. These patients frequently need specialized management, sometimes even non-oral forms of repletion.
Okay, that paints a very clear picture of the high-risk profile, but it leads us right into the next big area, the controversy around screening and diagnosis. Given how common deficiency is and how strongly it seems linked to bad outcomes, the temptation is always there. Screen everyone who comes through the door, right?
It's definitely the intuitive move, I understand that. But the consensus, based on the evidence we have now, is pretty firm. Universal screening for all inpatients is just not supported. The reasoning is straightforward. The large intervention trials that were based on general screening haven't shown that finding and treating mild deficiency improves major clinical outcomes in the broad acute care population. Screening really only makes sense if the result leads you to do something that demonstrably helps the patient in a meaningful way.
So the pendulum has swung firmly towards targeted screening. Who are the high-risk groups where testing that 25 OHD level is actually recommended?
Yeah, testing should really be reserved for patients where the result is likely to change management or help diagnose an underlying condition. This includes older adults, especially those with a history of falls or fractures, patients with known osteoporosis or osteopenia, definitely those with malabsorption syndromes we just discussed. Also, patients with chronic kidney disease, specifically stages 3 to 5, liver failure, and obesity BMI over 30. And we should test patients if they have unexplained hypocalcemia or biochemical evidence of secondary hyperparathyroidism, and of course those on the interacting medications we mentioned, because we need that baseline to guide dosing.
And when we do screen, the test is total serum 25 OHD. But let's touch briefly on the assays themselves. Does it matter how the lab measures it? Is there a gold standard?
Oh, it matters immensely. The gold standard for accuracy and standardization is liquid chromatography, tandem mass spectrometry, or LC-MS-MS. This method can separate the D2 and D3 forms, and it's less susceptible to interference from other molecules. Immunoassays are generally cheaper and faster, which is why many labs use them. But they can sometimes struggle with standardization, and there's concern they might over or underestimate the true level, particularly at the lower end of the range, exactly where the clinical decisions about deficiency are made.
So if your hospital uses an immunoassay, it's important to know if it's properly calibrated against LCMS MS values. That ensures you can rely on the number for clinical interpretation.
Absolutely essential. And besides the 25 OHD level itself, we often need other labs to get the full picture. Things like serum calcium, phosphate, and intact PKH. These are especially useful when you're working up low calcium or suspected bone disease or secondary hyperparathyroidism. The PTH level in particular is like a physiological anchor. If it's high, it tells you the body is sensing low calcium effect, usually because of low vitamin D or kidney dysfunction.
Now, let's tackle the really big shift, the 2024 Endocrine Society update. Many of us, myself included, were trained for years to aim for a target level above 30 nanograms per milliliter. What exactly changed with that new guideline?
Yeah, this represents a pretty fundamental shift in thinking, and it really reorients practice. Historically, we used thresholds. Deficiency was less than 20 nanograms per milliliter. Insufficiency was kind of this gray zone between 20 and 29, and the goal was generally over 30. The major change in 2024 is that the Endocrine Society's expert panel looked hard at all the RCT evidence. Their conclusion was that they could no longer endorse using fixed 25 OHD thresholds for routine screening or classification in the general population.
So they aren't saying vitamin D is unimportant, but rather that the evidence just doesn't support aggressively treating, say, a level of 25 in an otherwise healthy adult just to hit that magic number 30.
Precisely. It's a reflection of a rigorous look at the RCTs. Those trials largely failed to show that intervening when levels were above 20 nanograms per milliliter actually provided benefits for non-scalable outcomes, things like reducing infections, lowering mortality, or preventing chronic diseases like cancer or cardiovascular disease. So it strongly reinforces the need for an individualized approach driven by the clinical picture. We should be treating the patient with documented bone disease or truly severe deficiency, not just chasing a number in everyone.
That perfectly sets up our next section. The hard data from intervention trials, especially in critical care where deficiency is so common and the potential impact seems highest. We've established the strong observational link to bad outcomes. But what actually happens when we intervene, when we give high-dose supplementation?
And this is where we hit that RCT paradox. Deficiency strongly predicts things like mortality and longer stays. Yet the intervention trials, particularly those looking at unselected general ICU or hospital populations, have produced really mixed and often frankly disappointing results for those major outcomes.
Let's drill down into the key trials that really shaped this view, specifically VIT-ICU and Violet. Who are they studying and what did they find?
Right, both VIT-ICU and Violet were large, well-conducted trials looking at high-dose vitamin D in general, unselected critically ill patients, and the dosing was quite aggressive. They used a high-dose loading strategy, typically giving a very large single dose or maybe a few large doses enterally, like 540,000 international units of cholecalciferol soon after ICU admission. The idea was to rapidly correct the circulating 25 OHD level, and they generally succeeded in doing that.
But did that rapid correction translate into better survival or shorter stays?
Unfortunately for the overall population studied, no. Neither trial showed a significant reduction in their primary outcome, which was typically 28-day mortality. And they didn't see a significant impact on overall hospital length of stay either. This failure obviously led to a lot of clinical questioning. If the association is so strong, why didn't fixing the number fix the patient?
That is the million-dollar question. Was it timing? Maybe giving it later doesn't help. Or was it absorption? Can critically ill patients even absorb that big enteral dose effectively?
All of those are potential explanations and likely contribute. First, timing. The active hormone, 125-OH2D, takes time to be produced and then exert its effects at the genomic level. A patient who dies within, say, the first week or two might not have had enough time to benefit, even if their 25-OHD level shot up quickly. Second, bioavailability is a real concern. Patients in shock on vasopressors often have reduced blood flow to the gut splanchnic vasoconstriction. This could definitely impair absorption of an enteral dose, meaning it didn't get into circulation effectively, even if levels looked better later in survivors.
But the story isn't entirely negative, is it? There was a specific subgroup where a potential benefit kept showing up.
That's right, and this is probably the most promising signal from those trials, and it really informs our current targeted strategy. Secondary analyses, looking back at the data, particularly from VIT-LICU, and also some ongoing studies like VIT-DLICE, consistently suggest that patients with severe deficiency, and here they usually mean levels below 12 nanograms per milliliter, might actually derive a benefit, specifically potentially a reduction in hospital mortality.
Okay, so that highlights a really crucial distinction. It's differentiating between treating mild deficiency, say someone at 18 or 19, which seems unlikely to help in the acute setting based on these trials, versus treating profound deficiency like someone at 8 or 10.
Exactly. When levels are truly down below 12, the patient is almost certainly experiencing significant physiological stress from its severe secondary hyperparathyroidism, profoundly impaired calcium absorption. It's biologically plausible, reasonable to hypothesize that correcting that degree of physiological derangement might yield clinical benefits, even if correcting milder deficiency doesn't seem to move the needle on major outcomes like mortality in the broader group.
And how does this relate to acute inflammatory illnesses? We saw so much discussion around vitamin D and COVID-19, for instance.
The underlying hypothesis is still relevant there. Deficiency in patients with acute illnesses, including severe respiratory infections, might worsen outcomes because of vitamin D's role in immune modulation, maybe tamping down cytokine storms, controlling inflammation. However, the data, even from the COVID era, still largely points back to the current standard. The association looks real, but routine, universal supplementation for all acutely ill patients, even if found deficient, isn't supported by definitive RCTs showing improved outcomes, outside of potentially targeting that most severely deficient group, those under 12.
So we need to remain evidence-driven, even when the association seems compelling. Okay, let's pivot to management then. For those patients we do identify high risk, maybe new osteoporosis, confirmed malabsorption, or that severe deficiency under 12, what's the practical strategy for repletion?
Right, so the general approach is targeted supplementation, usually with vitamin D3, cholecalciferol. That's preferred because it's effective and has a long half-life. The goal for repletion, typically based on optimal bone health, is to get that 25 OHD level above 30 nanograms per milliliter.
And what are the typical ways we do that? What are common repletion regimens, either in the hospital or prescribed at discharge?
Often, we use high intermittent doses initially to quickly build up the body's stores. Common examples would be giving 5,000 international units of vitamin D3 daily for maybe 8 to 12 weeks. Or another very common approach is 50,000 international units given once a week for about 8 weeks. Both of those regimens deliver a similar total dose over time and are generally effective for straightforward nutritional deficiency.
And after that initial high-dose repletion phase is done, what about keeping the levels up? What does ongoing maintenance look like?
Once repleted, maintenance therapy usually involves much lower doses, typically somewhere in the range of 1,000 to 2,000 international units daily. Or you could use an equivalent intermittent dose, like 50,000 international units, perhaps twice a month. However, and this is key, this standard dosing often isn't enough for certain patient groups. That's where we absolutely have to individualize the dose.
Let's get into those specifics, because understanding the altered pharmacokinetics and the need for higher doses is crucial. Starting with obesity, which is so common in our hospitals.
Yes, obesity, usually defined as a BMI over 30, significantly changes vitamin D requirements. Patients generally need higher daily or intermittent doses. The main theory is sequestration. Vitamin D is fat-soluble, so it gets trapped or sequestered in the larger amount of adipose tissue, making less of it available in the circulation where it's needed.
So we basically need to overload the system a bit to overcome that trapping effect and the larger volume of distribution. What kind of doses are we talking about practically?
Yeah, these patients often need doses that are maybe 2 to 3 times higher than standard recommendations. You might be looking at regimens like 7,000 international units per day, or maybe 30,000 international units once a week, or even 50,000 international units weekly just for maintenance in order to achieve and sustain levels above 30. It's important to reassure patients and ourselves that vitamin D is generally very safe in these ranges, but the dose really must be adjusted based on BMI.
Okay, moving on to malabsorption. Patients post-bariatric surgery or with conditions like Crohn's disease, that's a completely different problem kinetically, right?
It's a fundamental issue with getting the vitamin absorbed from the gut in the first place. Patients with established malabsorption, or those who've had significant parts of their bowel bypassed, especially after Roux-en-Y surgery, need much higher doses just to get some absorbed. Often 2,000 international units per day, or even more, might be needed. And for the really tough cases, the ones who just don't respond adequately to high-dose oral D3, we have to think about bypassing intestinal absorption altogether.
You mean potentially using the active form, calcitriol?
Yes. For severe malabsorption or for patients with end-stage renal disease who can't activate D3 anyway, we might need to use calcitriol, the 125-OH2D. But using calcitriol is different. It requires much more careful monitoring of serum calcium and phosphate levels. Because it acts immediately and powerfully increases calcium absorption, there's a much higher risk of causing hypercalcemia. For patients who've had recent bariatric surgery, we also need to watch them closely for secondary hyperparathyroidism. Rising PTH is a big red flag that tells you their calcium and vitamin D absorption is inadequate despite supplementation.
And finally, the elderly or institutionalized population. They're often deficient due to less sun and maybe poor intake, but they're also the group at highest risk for falls and fractures.
Right. For elderly patients, especially those living in institutions, empiric supplementation is very common and generally well supported by evidence, primarily for bone health and reducing fall risk. Doses like 800 to 2,000 international units daily are often used routinely. While they might need higher dose repletion if tested and found severely deficient, this kind of low-dose maintenance acts as a crucial safety net for preserving baseline musculoskeletal health in that vulnerable population.
Let's make sure we cover drug interactions again, because these are critical checks for anyone managing polypharmacy. We mentioned the CYP3A4 inducers speeding up breakdown. Can you give us a sense of how much we need to increase the dose for those patients?
Yeah, this is a really practical point. When a patient is chronically taking strong CYP3A4 inducers again, think phenytoin, carbamazepine, rifampin, these drugs significantly accelerate the liver's inactivation and clearance of the 25-OHD form. For people on these long-term, it's not unusual to need maintenance doses in the range of 5,000 to even 10,000 international units daily just to compensate. That's easily triple or quadruple the standard maintenance dose. If you fail to make that adjustment, you are almost certainly contributing to drug-induced bone disease over time.
What about drugs that interfere with absorption itself, aside from GI surgery or disease?
Anything that interferes with fat absorption can be a problem. Bile acid sequestrants, like cholestyramine used for cholesterol or bile acid diarrhea, can bind up fat-soluble vitamins. Lipase inhibitors, like orlistat used for weight loss, also reduce fat absorption. So vitamin D, being fat-soluble, gets caught up in that. If a patient needs these medications, you should advise them to take their vitamin D supplements several hours apart from the interacting drug. Or you might need to compensate with a higher overall vitamin D dose.
And we absolutely must remember the safety check around hypercalcemia risk when certain drugs are combined.
Absolutely critical. The combination of thiazide diuretics, which are commonly used for hypertension or edema, with vitamin D and calcium supplements, needs careful attention. Thiazides work partly by reducing how much calcium is excreted in the urine. So if you add increased intestinal absorption from vitamin D, plus potentially increased intake from calcium supplements, on top of reduced kidney excretion, you can definitely push someone into hypercalcemia. This requires close monitoring, particularly in older adults or those who might have some underlying kidney impairment already.
Okay, moving into our final section, monitoring and safety. Because managing this properly, especially with higher doses or in complex patients, requires vigilance. When should we actually be rechecking vitamin D levels after starting treatment?
Well, just like screening, monitoring should also be targeted. Routine monitoring isn't really necessary for most stable patients, just taking standard maintenance doses, like 1 or 2,000 units a day. However, we definitely need to monitor those high-risk groups. That includes patients with malabsorption, those with chronic kidney disease, patients with obesity who are on those higher required doses, anyone taking calcitriol, where monitoring calcium is paramount, and patients on those interacting medications like anticonvulsants.
And if we do start someone on a repletion course, say the 50,000 units weekly, when is the right time to recheck their level?
Generally, retesting the 25 OHD level about 8 to 12 weeks after starting the repletion regimen is advised. That gives the body enough time to reach a new steady state based on that dose. The result of that test then helps you decide on the appropriate long-term maintenance dose for that individual patient. And the target level we're usually aiming for, again mostly based on bone health data, remains typically greater than 30 nanograms per milliliter. Let's also quickly review the differential diagnosis for hypocalcemia when you see it alongside a low vitamin D level. Because especially in sickened patients, the cause isn't always just poor diet.
That's a really good point. Simple nutritional deficiency or malabsorption are common. They're probably the first things to think of. But when the patient is acutely ill, the picture can be much more complicated.
Right. You have to consider organ dysfunction. Chronic kidney disease, as we've said, impairs that final activation step. Significant liver disease can impair the first step, the 25-hydroxylation. Then you have acute conditions that can cause low calcium for other reasons, often functional hypocalcemia. Things like severe acute pancreatitis or sepsis, where calcium can get sequestered in inflamed or damaged tissues. And we also see it acutely after certain surgeries.
You mean hungry bone syndrome?
Exactly, particularly after parathyroid surgery, like a parathyroidectomy for primary hyperparathyroidism. When the high PTH level suddenly plummets, the bones, which have been starved for calcium due to years of high bone turnover, suddenly start rapidly taking up calcium for remineralization. This can cause profound, often symptomatic hypocalcemia. And if the patient also has underlying vitamin D deficiency, it makes it much worse, because their gut can't absorb the extra calcium needed to feed those hungry bones.
Finally, we have to touch on vitamin D toxicity. It's rare, thankfully, because D3 has a wide safety margin, but it can be serious when it occurs. What are the telltale signs and diagnostic features?
Yeah, toxicity almost never happens from standard therapeutic doses. It's usually the result of massive overdoses, either accidental, like formulation errors, or sometimes intentional overuse of very high-dose supplements. The clinical signs and symptoms are entirely due to the resulting hypercalcemia. So you see things like lethargy, confusion, apathy, nausea, vomiting, excessive urination, polyuria. And in severe cases, it can lead to acute kidney injury and even calcification of soft tissues as calcium deposits where it shouldn't.
So the diagnosis hinges on finding that high calcium level in the blood, plus a very high vitamin D level.
Yes, the key diagnostic features are hypercalcemia, combined with a suppressed PTH level because the high calcium feedback shuts down the parathyroid glands. And accompanying that, you'll find significantly elevated 25 OHD levels, usually way up there, typically greater than 150 nanograms per milliliter. It's also crucial to rule out other common causes of hypercalcemia, like primary hyperparathyroidism or malignancy, before landing on vitamin D toxicity.
And if you do confirm true vitamin D toxicity, what's the acute management strategy?
Management needs to be pretty aggressive. First, immediately stop all vitamin D and calcium supplements. That's mandatory. The cornerstone of treatment is aggressive intravenous hydration with isotonic saline. This helps dilute the calcium and promotes calciuresis, basically flushing the excess calcium out through the kidneys. For severe or persistent hypercalcemia, we often need pharmacologic therapy. Bisphosphonates, like pamidronate or zoledronate, are very effective. They inhibit bone resorption, which stops calcium release from the skeleton and helps lower serum levels. Systemic glucocorticoids, like prednisone, can also be used. They work partly by inhibiting intestinal calcium absorption, though they're generally less potent and slower acting than bisphosphonates for this indication.
That really gives us the full picture, from recognizing risk factors and targeted screening through individualized dosing right up to managing acute toxicity. This has been an incredibly useful deep dive into an area where the clinical approach has really evolved significantly in just the last few years.
It really has. And it's so important to internalize those key takeaways for daily practice. Yes, vitamin D deficiency is incredibly common in our inpatients, and yes, it's strongly linked to poor outcomes. But the paradigm has definitely shifted. We're moving away from routine screening of everyone and reflexive supplementation for every low number.
Instead, the current evidence-based standard really emphasizes targeted evaluation and correction. We need to focus our resources and attention on those with documented severe deficiency, those levels under 12 nanograms per milliliter, and on patients with clear high-risk conditions like malabsorption, obesity, or CKD, using dosing protocols that are adjusted for their specific needs.
And we have to carry that message from the 2024 Endocrine Society guidelines into our rounds. The lack of clear trial evidence supporting non-skeletal outcome benefits for treating levels above, say, 20, means our primary justification for treatment in many cases remains supporting mineral balance and bone health. We acknowledge the potential for other benefits in the highest risk, most depleted patients, but we can't promise it based on current RCTs.
That said, it absolutely leaves us with this ongoing clinical challenge, something every hospitalist wrestles with, I think. You have this robust observational data screaming about a 2 or 3-fold higher mortality risk with low vitamin D. Then you have intervention trials that are, frankly, mixed, especially outside that severe group. So how do we ethically approach the complex, sick patient who's maybe hovering just above the severe threshold? Say their level is 15 or 18. Do we treat? Do we not?
And that really is the heart of the debate that guidelines alone can't fully resolve, can they? It's this constant balancing act. On one hand, we need to respect the high bar set by RCT evidence, which often only confirms skeletal benefits or benefits in the most severe deficiency. But on the other hand, we have this incredibly strong clinical association data suggesting that maybe, just maybe, correcting the level in our frail, acutely ill patients might improve their overall recovery, might even impact survival, even if the big trials didn't show it definitively for everyone. So the debate continues, doesn't it? Between sticking rigidly to the general trial findings versus treating based on a compelling association in a specific, complex patient in front of you, it demands ongoing critical appraisal of the evidence, but also requires individualized clinical judgment. And it leaves you with that lingering question. Is the patient with a level of 15 really so physiologically different from the patient with a level of 10 that they don't warrant at least considering the potential benefit in the high-stakes setting of acute illness? That's something for all of us to continue thinking about in our own practice.